Our next talk is Defining Vascular Deserts to Describe Access to Care and Identify Sites for Targeted Limb Preservation Outreach by Dr. DeLosa, Senior Author Dr. Humphreys from UC Davis.
Good morning. Thank you for the program committee for the opportunity to present our work. These are our disclosures. Medical desert describes a community lacking access to primary care providers, hospitals, and other medical necessities. Over the last few decades, research has kind of explored the association between deserts and poor health-related outcomes among patients. Some of the earliest reports included looking at food deserts, which describe neighborhoods that lack access to healthy food, especially fresh produce, and have correlated these with poor health-related outcomes among residents. Other studies have looked at maternal care deserts, which describe regions with women who don't have access to maternal care and have associated these with poorer follow-up as well as maternal deaths. We've also explored deserts related to surgery, and most notably these have been trauma deserts, which have identified increased morbidity and mortality related to location, especially 30 miles outside of a major trauma center. With this in mind, we define vascular deserts as regions lacking access to subspecialty vascular care and sought to describe the patient population in these deserts. So specifically, we were looking at chronic limb-threatening ischemia. This affects more than 2 million U.S. patients annually, and it includes symptoms of debilitating claudication and rest pain, in addition to tissue loss, and up to 185,000 patients will ultimately undergo a major lower extremity amputation. The cost to treat these wounds is up to $25 billion annually and is expected to double in the next decade. Goodney et al. Have previously demonstrated the use of spatial analysis to describe regional variations and trends in endovascular interventions and major lower extremity amputations. And while disparate outcomes have been demonstrated among patients residing in rural areas, most prior literature has looked at access to care as a function of urban versus rural zip code rather than proximity to the provider offering this crucial care. So we conceptualized an approach that would allow us to map providers to identify vascular deserts, and that would eventually allow us to look at outcomes between desert and non-desert regions with relation to CLTI. So to describe vascular deserts, all providers performing vascular procedures from the state of California were identified through online provider and healthcare facility searches. Facility participation in VQI lower extremity bypass and peripheral vascular intervention modules was also determined. Provider addresses were then geocoded, and a 30-mile surrounding buffer was created using ArcGIS. Maps were created based on the type of care that was provided, including all providers offering vascular procedures, board-certified vascular surgeons, and facilities participating in VQI modules. On these maps, we overlaid public census data to evaluate population factors in desert versus non-desert regions. When comparing non-desert versus desert regions for the different types of care, we described the percentage of the population living 200% below the poverty line, the percentage of uninsured residents, and the percentage of residents who are white, Asian, Hispanic, and Black. The percentage of uninsured residents was typically equivalent or higher in non-desert areas and significant only in populations that were served by board-certified vascular surgeons. We thought this potentially represented what you would expect based on indigent populations in urban areas. And then the all-provider and board-certified vascular desert regions had a greater percentage of the population living 200% below the poverty line, likely reflective of lower income with increasing distance from major cities. And then the vascular desert regions had an overwhelming white majority in contrast to the slight plurality evident in non-desert regions, likely reflective of increasing demographic diversity in urban areas. In addition to census data, we overlaid the Healthy Places Index data to evaluate other traditional social determinants of health in desert versus non-desert regions. The HPI is a publicly available data set through the Public Health Alliance of Southern California, and it's through collaboration with multiple local health departments. The HPI data provides an overall score for neighborhoods that is made up of multiple factors that are associated with health-related disparities and poor health outcomes. These include education, economics, healthcare access, housing, transportation, neighborhood, social, and pollution. The mean HPI percentile was significantly lower in the board-certified provider and VQI facility desert regions compared to non-deserts. and correlated to worse living conditions and health-related outcomes in these desert regions. A more granular look at the factors comprising the HPI score revealed that economic and education factor percentiles were significantly lower in all desert populations. Residents in all desert regions were in a lower mean income percentile, had a lower percentage of the population finishing high school, and a lower percentage of the population finishing college. The healthcare access, transportation, and neighborhood factor percentiles were also significantly lower in the board-certified and VQI facility deserts compared to non-deserts. This corresponded to poorer health access at baseline among patients with access to specialty care, further limited by transportation and residents in these regions. All of these findings maintain significance in multivariable analysis when accounting for urban versus rural zip code by census tract data. In conclusion, access to care is a complex issue, and it's determined by more than just provider proximity. Our results suggest that efforts to reduce the burdens imposed upon patients living in vascular deserts may be warranted. For instance, while telehealth programs cannot address all disparities related to traditional social determinants of health, for patients that deal with poverty and transportation issues, they may provide a solution. Moving forward, we think that this information can better help us serve these patients by identifying particular patient populations that may benefit from targeted outreach programs for CLTI. And then our next steps include overlaying the Office of Statewide Health Planning and Development data to evaluate outcomes related to CLTI. Thank you, and I'll be happy to take any questions.
Thank you for that great talk. My question is about looking at vascular care as a whole, since it's very multidisciplinary and also multimodal. So with this targeted outreach program, what do you see that envisioning? And then in terms of actually intervening upon patients, there's a set of resources that we usually need for intervention. So would you propose trying to get that out into the community, helping people come to us instead? And if that's the model, how did we then continue follow-up imaging, things like that? Because these people who are in desert populations, it's not just a primary or vascular surgeon. It's usually all forms of medical care.
Thank you for your question. We actually agree with you, and funny you should ask. Dr. Humphreys has a model that she has been using in her practice that actually works to address some of these questions that you've asked. Essentially, her model allows her to screen and establish care for patients in remote areas using telehealth modules. And she works with the providers in those areas to determine what these patients need using testing modalities such as ABI and ultrasound in the community. And only once she's determined that a patient needs an intervention, whether that be surgical debridement, bypass, endovascular intervention, does she bring that patient into the hospital to limit the number of times that they are forced to travel to a facility that's significantly farther away from them than your average patient. We actually do partner with a lot of other providers, including podiatrists, and that kind of brings in the element that you were talking about, including multiple providers. And I think you have to really evaluate what an area needs to determine how best to help them. Maybe they have access to podiatrists. Maybe they have access to primary care providers that are willing to collaborate, and all they need from you is the ability to understand the results and offer revascularization when needed.
That's great. Can I ask a follow-up question?
Absolutely.
How do you then disseminate that model and perhaps even incentivize that model to go elsewhere?
Really good question on the incentivization that we're still working on. As far as the model, we're actually going to be publishing a lot of that information in a special issue of seminars, I believe next month. So look for that.
Congratulations. Thank you.
Thank you.
Dr. Coleman.
Yeah. Hi, Dawn Coleman at Duke. Dr. DeLosa, that was really beautifully presented. It's so important, and as somebody who's recently moved into a part of the country where there are real deserts in our state, a lot of your messaging resonates with me, and I think it obviously replicates in different parts of the country. I really just want to ask your thoughts on a few things, though, because you've highlighted a problem, and I do think the role for telehealth and other strategic outreach is so important. But in this particular patient population, what I'm observing locally, at least, is that patients are coming to vascular surgeons with tissue loss, often at such an end stage of their disease. And there are so many other factors that contribute to perhaps our inability to salvage their limbs. There are challenges with mistrust in the medical care system. Telehealth is limited in some of our patients who don't have access, who frankly can't read, or there are language barriers. There are just many, many, many things. And I just wonder, as you think about this going into your career, because this is a really important space for us to think about as vascular surgeons, how do you think about optimizing care at an earlier stage in disease in a way that leverages perhaps other stakeholders and not just the vascular surgeons on the end of that spectrum? Thank you so much.
I think that's a very important question and kind of gets to a topic that we've addressed numerous times in vascular surgery. I think you have to start at the beginning. The caretakers for these patients typically are their primary care physician. And many times they'll see a primary care physician and still not make it to a vascular surgeon until it's far too late. So I think the place that we start is by educating our primary care providers in all of the regions immediately around us and further out. If you know that there are areas that don't have access to providers that are so necessary for good outcomes, then it falls to us to work our way into those communities as well. And that is, I think, where we start to make a difference in these patients' outcomes.
Great presentation, very timely. I think of a desert region which is called the pandemic, where we really changed how we were able to interact with our patients. So I think hopefully we can learn something from the pandemic and how to get out to these patients, whether they're trapped at home or trapped in remote areas. The question I then go into the business model: how are you setting this? How are you managing for reimbursement for that? Because during the pandemic, we did get provisos that even out of state, we could actually bill for these interactions, even though they were virtual. And then finally, what's the liability issues? If you're not actually seeing the patient, but you're making recommendations, is there a medical legal liability?
So luckily with COVID, one of the few positive things to come out of COVID was the improvement in telehealth services that we're able to offer. Reimbursements are improving there as well. And what we have found specifically related to being able to provide care to these patients is that you can look at imaging studies. You can kind of direct these providers in ordering the appropriate tests to go through a workup for these patients. And while it may not be the ultrasound or ABIs that you're used to, they can give you some valuable information, and you can work to educate these providers on how to perform the basics of a vascular exam and what we're specifically looking for whenever we evaluate a patient, whether it's how long the wound has been present, whether or not they have risk factors for vascular disease, whether they're on best medical therapy. Those are all things that we can work to educate providers on, and we can actually, telehealth does provide a module for educating other providers and providing care to their patients, and there is reimbursement available for that as well.
Thank you.